Good morning and welcome to day 2 of the Free to Care virtual conference. Yesterday we touched on interacting with hospital politics, the health and well-being of physicians, how to advocate for yourself politically, and then of course the efforts on mock litigation. And I hope that the undercurrent that you were able to get from that was that we're solutions based, and there's an undercurrent of hope, and that's really the key for why it is that we do what we do, because healthcare reform is pretty daunting, and many people have said this is just too big, and how on earth can we possibly make an impact? I'm only one person, and I'm not very important. I just do what I do on a daily basis, and I try to pay my bills and take care of my family. But I want to be able to encourage you through our sessions today to say, look, there are solutions, and that's the focus that we need to have. It's too easy to complain and to talk about the wrongs that are being done in our society and to ourselves. But it takes a good bit of effort and again, the undercurrent and underpinning of hope to say, I'm going to be a part of the solution. And so today we're going to talk about some solutions. We're going to talk about physician shortage. We're going to talk about rural health care, what's going on in the legislature and how you can be a part of it. We're going to talk about the innovations that are currently in place in healthcare, and that will be a part of the change in this industry that we all love. And then, of course, we're going to have some experts talk to us about drug pricing and what's going on there, and how we can continue to make an impact there, because our coalition has just been at the forefront, thought leader in that piece of subject matter. But this first panel is a great group. You're going to enjoy it, and I think that this technology in this conference is a testament to how things can be done in the future. We have people from all over the country, and one of them in the country currently in a deer blind. So you'll get a great kick out of our panelists and what they'll have to say. This is a wonderful group. Enjoy today.
All right. Thanks, David. All right, I'm going to start off. I don't know if Brennan, you going to do an introduction?
Yeah, I'll give a quick overview on how to use Zoom for all the attendees out there. Each panel will be roughly 60 minutes, 50 minutes of discussion followed by 10 minutes of Q&A. Or also, Nikki, if you would like to, just in between just discussions and talk, check out the Q&A section. It's kind of how we did it yesterday, and have those questions kind of flow in the panel. That seemed to do well. And then at the hour mark, I'll just transfer everyone out, all the panelists, and bring in the new panelist. So pretty straightforward, and we can go from there. So Dr. Nikki Johnson, please, you have the floor.
All right. Hey, good morning, everybody. Thanks, Citizen Health, for sponsoring this event. It's very exciting to me to continue to be a part of Free to Care. My passion, one of my many passions, is to make sure that we are practically solving the physician shortage. As of right now, we know that there are projections that state that from the American Association of Medical Colleges, about 42,000 at minimum, up to 121,000 physicians will be needed by 2030. And that is assuming that all of the barriers to getting affordable and equitable and timely care have all been erased. Unfortunately, that's magical thinking at this current state, because we haven't really been solving the problem from a federal legislative end, or even local and state agencies haven't really adopted real measures that are actually going to help fix these gaps. I mean, just an example, in Texas, 32 counties have no physicians at all. And 157 of all the 250 plus counties in Texas don't have an obstetrician, meaning women who are pregnant who have a way to get care during their pregnancy, or even after the baby, during the time the baby is delivered, and they have to seek care outside of their own county. One of the biggest effects of the Affordable Care Act was to pave the way for states to allow non-physicians like advanced nurse practitioners or nurses to care for patients without the supervision of a physician. But and at this point, 24 states plus the Veterans Association administration has allowed a high volume of these practitioners in the workforce. But the data shows that these NPs are practicing in areas already covered by physicians. So the rural areas, our citizens are, to quote our Free to Care paper that we published back in April, they're the food, the fuel, and the fiber for our country. If we don't take care of people in these communities who are desperately relying on Medicaid and Medicare, we're going to lose a great, valuable resource to our nation. So today our panel is really going to focus on solving the care, the access to care, and the physician shortage, predominantly in rural areas, in rural communities, affecting all ethnicities, and the population that specifically has a high reliance on Medicaid and Medicare. So first we're going to get Mr. Carl Schuessler in. He's a managing principal of Mitigate Partners and Benefit Strategies. He's a consultant for Medicare or medical care organizations, and he really described himself as being engaged in the pursuit of employer-built healthcare, which will replace the insurer-built healthcare system he affectionately calls the cartel. So he's going to start off giving us specific examples of a recovery project that actually helped a rural hospital. And then we're going to have Dr. Sheila Page talk about some solutions for improving the quality of rural medical delivery. Dr. Page is a board-certified neuromuscular medicine and osteopathic manipulative therapy physician. She currently serves as the president of the Texas chapter of the Association of American Physicians and Surgeons. She also served on the Texas Rural Health and Economic Development Advisory Council. And then finally, we're going to hear from Mr. Andy Mangione. He's passionate advocate for older Americans. He serves as the Senior VP for Action Leadership Team of the Association of Mature American Citizens, otherwise known as AMAC. Andy is going to discuss the Pro Bono Care Act of 2019 as a way to free your physicians and other practitioners to care for you when you cannot afford to pay. And then we'll kind of take questions as we go through this and questions as at the end. So Carl, take it away.
Thanks, Dr. Johnson. Let me share my screen. Brendan, let me know if it's going. Am I good, Brendan?
You're getting there. Yes, you're streaming now.
Okay, good. All right. Thanks, everybody. And I want to thank Citizens Health and David Blatt for having me here in the spirit of rural health care. I'm slap in the middle of middle Georgia in a deer stand. This has kind of interrupted my hunting, but when David asked me to do it, I told him I was going to be in a deer stand. So we're right in the middle of the rut season down here. So first off, big day today. It's the world's largest outdoor party. I'm a Georgia Bulldog, and it's great to be a Gator hater. So we're playing the Gators today. And I just want to throw a couple of things with those tank top jort wearing Gators. It's been 1,099 days since the Gators have beat my Bulldogs. So just wanted to throw a little love out there. All right, let's get it rolling. So what we're going to talk about is building employer-built healthcare versus insurer-built healthcare. Do active management versus traditional passive management. I'm going to go into each of these. Relocalized care, the repersonalizing of healthcare. And then focus on building community-owned healthcare versus building the archaic insurer-owned healthcare. And really to maximize a local care team, the pharmacist, the physician, the hospital, and the patient. Back to Marcus Welby MD days, neighbors taking care of neighbors. And again, through active management, you can offer employees 10 times the benefits for half the cost, as you'll see in this case here. And there is a way for employers to have health insurance on their terms, their way, and that's what we were able to do here. If you don't get enough from this, you're welcome to go check this podcast out. The whole story of this hospital is in 40 minutes, 2 20-minute sessions. So check Christy Gupton's podcast out. I want to also thank the leadership at the hospital, Vince Sika, the CEO, who also is a Florida Gator, and he's actually in Jacksonville right now, Vince, so I apologize for that early stuff. Dan Hogan, CFO, and Lois Helton, HR Director. It's a state hospital district, 49-bed community hospital, about 220 employees or 157 employees on the plan. So let's kind of look through the challenges they were faced with. They're the 4th poorest county in Florida. This is in South Central Florida. Per capita income of $25,406. The BUCAs, when I say the BUCAs, that's Blue Cross, United, Cigna, Aetna, Humana. We're extracting millions from the community. So quickly, this is a slide I talk about a lot. Dr. Johnson referenced the cartel. Look at the top 20, Fortune 20 here, and look at the companies that are involved. And you'll notice that you'll see United Healthcare owns Optum. They're number 5, excuse me. CVS Caremark's getting acquired by Aetna, and Express Scripts getting acquired by Cigna. I don't know how the DOJ operates. I'm not a politician, but I sure don't get how they can allow that to happen. These people have extracted millions from Americans, and they've extracted millions from this county that we were working with this hospital. Passively managed risk. They were not actively managing their risk. They lost obstetrics in February of 18. Members have to drive an hour for deliveries. Anybody in the county has to drive an hour because they couldn't afford to have obstetrics anymore. And Nicole referenced that earlier. Foreign medical spend, that's all the spend going away from their hospital by their members, those 157 employees, the last 4 years was 79%. They don't do everything there, but that's an awful lot to leave. And their spend in medical and RX was about $2.2 million when we met them. And we got hired in August of 18. And here are some of the solutions we put in. Eliminate the middles. We implemented a program we built for the last 7 years called the Fair Cost Health Plan. Moved from the BUCAs, the insurance companies, administrative service model, to an independent TPA. So we eliminated all the middles, all the middle people, middleman. Active management eliminated passive management. Let me give you a quick rendition of what this is. Most employers use what we call, they hit the easy button. They're hiring an insurance company to manage their benefits and pay their claims, and they're processors is what they are. They process claims. They don't pay them. They process the claims with the employer's money and the employee's money. We call this BUCA Insurer Built. And when we met the hospital, they were a BUCA Insurer Built plan. It's passively managed. What we're talking about doing it is brick by brick, with the foundation being direct primary care. This is what we do. We sat there on October the 1st, 2018, from 1 in the afternoon to 6 in the evening with the team and some of our partners building this plan. And we call it employer built healthcare, brick by brick, picking the best bricks. So we deconstructed and rebuilt it. And that's what we call employer built healthcare. We relocalized care, getting back to neighborhood healthcare. The world is a big place. This is South Central Florida. By relocalizing care, you can build a community health plan. If you look at this little blue circle in the middle of that circle, we're talking about building the community. We're talking about growing the hospital, getting outreach to all the community and surrounding towns. Things like they do, Dr. Lee Gross will talk about in a minute, was able to coordinate a $25,000 knee replacement, bringing a surgeon in from Sarasota, Florida. The average going price in the surrounding counties could be up to $100,000. So that's what we were able to do there. And this is I'm going to let y'all read this, but if you eliminate the counterproductive barriers inherent into traditional insurance, where you have insurance companies, pharmacy benefit managers, and all the people trying to manage the care of the patient, it gets very cumbersome. My father was a 40-year OBGYN right here in this town where I am, Macon, Georgia. And the insurance companies were it was awful for him to try to deal with them. He couldn't practice medicine. So we eliminate that hassle and get it back to local care where it's supposed to be. All right. We utilize a cost and quality transparency tool with direct cash pay. We were able to let these employees know how to get to the best best physician at the right time, the right place, and lastly, right quality, and lastly, right price. And so we have a tool they all use. Here's what's really criminal to me that really frustrates me, and everybody gets me going about the cartel. BUCAs know about provider costs and quality, yet they stand passively by and pay $40,000 for one knee, and 2 feet away from them, the other hospital is $135,000, and they're doing it with your money. And so what we're able to do with a hospital is we were able to fix that. We offer 10 times the benefits for half the cost. You're going to see in a minute. We weaponized the land, and the hospital became their own pharmacy benefit manager. For the audience out there, if y'all have ever heard of PBM, that's program bilking millions. Not anymore. We've done away with that. Let me give you a quick example of what I mean by this. This is the pharmaceutical shell game, the PBM shell game. And when I talked about the Fortune 500, many of these companies are in it. So I want you to look at this. Obviously, you can tell I'm sitting in a deer stand. I'm not the sharpest knife in the drawer, but I know there's a lot of money changing hands here. And this is how drugs are delivered to members in a health plan. Pretty confusing. So there are your manufacturers. There are your wholesalers. Every one of those was in the top 20 of the Fortune 500. And then your pharmacy benefit managers we just talked about. And those are the 3 biggies, and that's where they are. And then the pharmacies that deliver the drugs. What we've been able to do is got rid of the pharmacy benefit manager PBM, and we made the hospital their own PBM. And we've also had special arrangements with community pharmacies where the drug copays are less at community pharmacies. That was really important. Keep the dollars local. Here were some of the plan changes that we have effectively started January 1st. We have a rich plan, eliminates deductibles and co-insurance. People haven't seen no deductibles and no co-insurance in 30 years, folks. Low copays, no barriers to care. So they had 3 choices. They could go to DeSoto with no deductibles, no co-insurance. They could go to the friends and family hospitals we identified and had direct contracts with for a little bit out of pocket, but not a lot. And then if they want to go anywhere else, they want to go to the Mayo Clinic, they want to go to the Cleveland Clinic. Their program before did not allow them to do that. They can go anywhere in the country. If they want to come here to this deer stand and me to perform surgery, they can come here. It's covered. I don't hear any laughter out there. All right, we implemented direct primary care. This is Dr. Lee Gross, one of the top DPCs in the country, was right there when Trump signed the executive order in July. Lee is how I met, Dr. Gross is how I met David. His organization has been huge. So we have a hospital that has physicians employed, and they put in direct primary care. The hospital saw the foresight, and Dr. Gross brought us to the table, and that's how we were able to do this. And why DPC, I'm not going to spend much time. I think most everyone knows why. They offered this DPC to the employees for no cost. So they can see Dr. Gross 20 times a day if they want to. Now, he may hit me for saying that, but they can. And then we implemented some proprietary claim analytics to analyze the data, and we integrated coordinated care very quickly. We were with a BUCA. They were the BUCA for 5 or 6 years. We analyzed the data. We identified 66 people who had the following conditions. We put them into lifestyle management, active disease management, and chronic care management. We identified 66. Within 3 months on this platform, 31 more people were identified that the other BUCA never caught. That's what it means to get good data. Data's king that makes this happen. Results, we relocalized care. We got neighborhood health care. We saved them $150,000 in their stop loss. 58% savings on their fixed cost to run their health plan. Because fair costs and all the cost containment provisions and weaponizing the plan design, the stop loss carriers rewarded the hospital for that. Offered 10 times the benefits for half the cost, weaponizing the plan design. This is key, guys. We went to 62% of foreign medical spend from 79% last 4 years. That is huge. They had people come to their hospital that were employed there who had never had care in the hospital because they had a deductible before, and we made it easy. And by the way, this hospital is an excellent hospital. It's a 4-star CMS hospital. They also hired their first full-time surgeon in county history. Significant. And their renewal of their stop loss plan, they got a rate decrease. A rate decrease, second ever in the history of this insurance carrier who has been in business 40 years. And here's the savings. 1.2 million or 54%, 10 times the benefits for half the cost, as we said earlier. Real quick, just to see it looking, we started this in October, went to our fair cost program in January, and you can sort of see the results for yourself. They spent less than $1 million, folks, when they were spending 2.2. Red bar represents where they were, green is where we are today. So Now, what are we doing? We're taking it to the streets, in the words of the Doobie Brothers. We're going to the city, the county, and the school. And the medium and large employers, we've been talking with the city and county school for almost a year. We're finally getting traction, and we're trying to bring them together to offer the same plan to them and build a community health plan and keep the dollars local. We also have a very large employer that's talking to us as well. So again, this is the hospital. I appreciate your time, and if anybody has any questions, I'm glad to help. But guys, it is absolutely possible. You can't solve the problems with the same thinking we used when we created them. Got to make a change. And I just want to thank the hospital leadership and for the foresight to do a lot of these programs. And I think it's been a great win-win for everybody. And we'd love to help any rural healthcare system out there. It absolutely is possible. Thank you.
Thank you, Carl. Marion Mass, actually, Dr. Mass asked a couple of questions that were specifically directed to you, but she put them in the chat, so I'm going to actually read them. Just a reminder for everybody to please put your questions in the Q&A section, not the chat. And for everyone who is not speaking, if you're not automatically muted, please mute so that your background is not interfering with the conference. Marion's first question, Carl, is it a plan for only hospital employees? Are there a significant number of DPC practices in the area where you did this? And if you tried this in a county without DPC, would it be possible?
All right, Dr. Johnson, I'm going to do my best. I'm a little slow, so let me see if I can try to get that. So is this just for the hospital employees? This particular program was built for the hospital, but we're now taking it to the city, county, and schools where they can also put in a program like this and be in this organization. They could do what's called a captive potentially, but yes, it's all the self-funded employers. As far as direct primary care, this hospital sited in one county, obviously DeSoto County, and the direct primary care practice of Lee Gross and Dr. Crouch is right there on the premises. As far as expanding it, or when you get a hospital that may have 3 or 4 locations, that's where direct primary care can be challenging, but there's a lot of ways of connectivity, and it can work if you don't have DPC in another place. You just have to have different plan designs. Then what was the third question?
The third question is if you tried it in a county without DPC, would it be possible?
Yeah, it would be possible, absolutely. But I'm gonna say this: I'm such a huge proponent of direct primary care. There's so many great physicians out there. I mean, I watched my father 40 years in practicing obstetrics and gynecology, and there's nothing like having a doctor that you can have a personal relationship the way it used to be before, the early 90s when managed care came and ruined it. So it will work without it. I think it's a key building block, but we have other plans, Dr. Johnson, all over the country that don't have DPC, but we're trying to get it in all of them.
Okay. And Dr. Mass has a couple of more questions too. She wants to know, did you contract directly with suppliers for all hospital supplies? If so, do you have the data on how much you spent on these hospital supplies versus another hospital of comparable size? And she'd like to know how direct buying without the group purchasing organization compares.
That's a great question, Doctor. I need to get back to my hunting here, but I'm going to try to answer that. Honestly, I'm not equipped to answer. That's a question for the hospital leadership. You're talking about like surgical supplies and things like that. Is that what she's referencing, Dr. Johnson? Or, beds to whatever type supplies a hospital would use?
Yeah, all the supplies that the hospital would use, and
yeah,
without negotiating with a group purchasing or organization.
Right. You'd have to ask the hospital leadership what they do on that. We're just helping them run their health plan.
Okay.
Sorry, I couldn't answer that question. That's out of our scope. I apologize.
Okay. And do you see this working with within system hospitals or like these big corporate hospitals, or do you think this is more effective for small community hospitals and rural care centers?
I think it can work anywhere, Dr. Johnson. I mean, Mercy Hospital up there in Kansas City is doing some cool stuff. I was at a conference, ACO Direct Contract Symposium conference a few weeks ago, and heard from the person at Mercy. So I think it's possible in any. But when you look at HCA, Tenet, CHS, I mean that's probably a little tough. And those hospitals, we have a lot of experience direct contracting, and they're not the easiest to work with. That's what I'll say. But I think it's probably smaller systems, but I do believe it's possible. It's just it's up to that company. I mean, what we do, Dr. Johnson, is I say it's not different. It's right. It's the right thing to do. And they don't want to hear that. And they're in bed with the bucas, think about how these hospitals contract and work. So a lot of them are not going to be open to this. But when your back's against the wall, you got to do things. And I think if you were to poll those employees in that hospital and ask them this, do you want a single payer system, or do you want what we have with fair cost? I guarantee you they're going to say, we want fair cost. We don't want single payer. Why would they? Free care, free direct primary care. So it absolutely is possible. You just have to get to the right leadership to discuss it.
All right, great, Carl. There's a couple more questions coming in, but we're going to save those to the end, and let's let Dr. Page give her points about rural care. Thank you.
Thank you, Dr. Johnson. Make sure my screen comes up. So I'm going to focus on some of the issues related to the hospital closures in the rural areas and try to explain why it's different than the corporate hospital problems that you see in the urban areas of the United States. And I'm trying to get my slide to work. Brendan, if you can help me. I'm not getting a movement here. So as Dr. Johnson had brought up, the food, fiber, and fuel of our nation is coming from our rural areas. This is why it's so very important that we tend to the needs of our rural areas, and that includes making sure that the hospitals are healthy. And farming and ranching, which is primarily the occupation of the people that are living in these areas, is one of the most dangerous jobs in the United States. And so trauma is an important issue that needs to be addressed in these hospitals. And so it's very hard when you can't keep a surgeon in a hospital to be able to meet the needs of your community. And not only that, most people don't realize that in the rural areas, all of the highway accidents, car accidents, are going to end up in the rural hospitals first. Because they are transported to the nearest facility. Another reason why keeping these hospitals viable is so important. And Texas, unfortunately, leads the way in the nation for rural hospital closures. We've had over 21 closures now since 2013. I think Tennessee follows us, and then Georgia. And 72 of our counties do not have a hospital. We started off with 300 hospitals in the 1960s, and now we're down to 161. This is a diagram that illustrates the major reason for the hospital closures in the rural areas. In the 1960s, it was government regulation that started the first wave. Again in the 80s, and then in 2010. Every time the government imposed sweeping regulation on the hospitals, we had a wave of closures in the rural areas. The major contributing factors to rural hospital closures are EHRs as one of them, because the cost of changing software is huge when you have a small financial margin, that like what they have in the rural hospitals. They don't have the patient volume or or the type of patient population to support that kind of cost. They also have the highest levels of uninsured in the nation and higher levels of Medicaid and Medicare, which makes them very dependent on the government reimbursement for their income. So when Medicaid underpays or Medicare cuts end up hurting the rural hospitals, it can close a hospital quickly. And that's what has been happening. So just for example, in Texas, the Medicaid underpayment amounts to about $65 million to the hospitals, and Medicare cuts about $50 million a year. Some of the regulatory costs that is imposed on the hospitals that tends to be a problem is the unfunded indigent care that's mandated. That's paid for by property tax, and if you've got a small community, you're not going to be able to sustain that. Another thing that a lot of people don't consider is the quality measures that are imposed on hospitals in general can really hurt rural hospitals because they're so costly. And one of the examples is sepsis workups. They're the most common admitting diagnosis for cancer patients, and yet most of them don't have sepsis when they are admitted into the hospital. It's an inappropriate application of the checkbox protocol, actually, that ends up forcing a sepsis workup that was unnecessary. If you do that too many times in a rural hospital, you're going to bankrupt them because it's a very costly and unnecessary diagnosis and treatment cascade. Another problem that the rural hospitals have is just simply the federal regulation imposed by their definitions of what qualifies them for reimbursement. So there are lots of rules. For example, a 96-hour rule that requires the hospital a critical access hospital to discharge or transfer a patient within 96 hours or they don't get paid. And that's really an unreasonable imposition to put on a rural hospital, because if the patient needs to be there longer, then it's extremely expensive to transfer them, and it would be inappropriate to discharge them. And again, the dependency on Medicare and Medicaid is what makes rural hospitals so vulnerable, because they don't have the patient volume and the patient population to sustain the burdens that come with that reimbursement. And some of the things that contribute to that are just the many federal rules. And that's where we need to make changes. We need to change some of the definitions that make it impossible for them to operate in a normal fashion, and look at how they're reimbursed, which the reimbursement tends to benefit the big corporate hospitals in urban areas, but they punish rural hospitals. The physician shortage that we're seeing across the nation is really in many ways a physician time shortage, and we have to keep that in mind too. Sometimes what we call a physician shortage isn't really the number of bodies, but the amount of time the physicians have to see patients. And just an example in Texas, now what's happened in the rural areas with physicians, we have 32 counties with no physician at all, and 157 counties with an obstetrician. And obstetrics is a growth factor in a community. If you can't sustain an obstetrician, if you can't provide that kind of care for families, then you're going to have a really hard time growing a community and keeping it viable. And this map demonstrates how bad our situation is. The red dots are the hospitals that have no labor and delivery in Texas. The the green ones are rural hospitals that have labor and delivery. And many hospitals can only provide labor and delivery on an emergency basis. So some of the solutions are actually, we're going to have to come up with alternatives to Medicare and Medicaid, because that dependency is part of what's creating the problem. And also investing in growth industry models. And one county in Kentucky actually did that with obstetrics, and they were able to turn around their hospital situations by making obstetrics more available and providing good care, which grew families, and it made it easier for families to feel comfortable staying in that area because they knew that they could get the care they needed. Another way that we can increase the number of physicians that are in the rural areas is by looking at how we train our young physicians and how we recruit them. And they found that physicians will stay in a rural area if they've grown up in a rural area. And one of the biggest problems with the residency programs is that the students that enter them intending to go to a rural area find out they don't really like it there if they've never had the experience, and they don't stay. And so what one school in Texas did was create a 7-year primary care pathway program. This was at UNT in Fort Worth. And they used federal grants to collaborate with rural areas that had a community college, a hospital with a residency program, and they were able to recruit students beginning in high school. They would take promising students who were interested in medicine and start them in a more intensive training program in the junior college there in the community. And after 2 years, they would be able to then go immediately to the university in Denton, finish a 3rd year there. And if they succeeded in their program, which was, it was a very demanding program, then they were able to be granted immediate admission into medical school. So some of the parts of the program that were really beneficial were the intensive, the enriching programs that they gave them during the summertime. They kept them in touch with clinics in the rural areas. So the area that they were recruited from provided clinical experience and guidance to them during the summer, so that they always had exposure to clinical experience, and this kept their interest in rural medicine and also kept them in touch with the community they were recruited from. After they finished medical school, the agreement is that they return to their community and do the residency in the place that they were recruited from. And this program's been working well, and it's allowing the students to be able to meet the needs of the rural community. Excuse me. So I think that the rural medicine is one of the areas, because we have such a high need and because the current system's not working for it, it's a good opportunity for us to develop a new model of hospital care and use some of the innovative ideas that Mr. Schuessler presented and other people have come up with, and let it be a foundation for changes in medicine for the future. And that's it. Thank you.
Hey, Nikki, you're muted if you're talking. Hey, Nikki, you're muted.
Yes, I am muted. Thank you. I see one question here. My son would like information about how to apply for the student program. Dr. Page, do you have any information about that you were speaking of?
Oh, the program that I was talking about is it's at UNT at the Texas College of Osteopathic Medicine, and Dr. Lisa Nash runs the program.
All right, thank you for that. All right, continuing on, Mr. Andy Mangione, you're up.
Thank you, Sheila. Thank you, Dr. Page. Thank you, Dr. Johnson. Thank you, Carl. I'm Andy Mangione with AMAC, and AMAC is an acronym for the Association of Mature American Citizens. For those who are unfamiliar with us, we are a chief competitor, the chief competitor to AARP. We're a member benefits organization for Americans who are age 50 plus, 2.2 million members across the country. And I appreciate the opportunity to join this panel to talk about charity care. Specifically, nonprofit hospitals and their affiliate facilities all have an obligation to meet the needs of their patient population, including the needs of the uninsured patient. And many facilities are faced with the challenge of obtaining sufficient physician services or physician coverage for the reasons Dr. Page just went through, among others. Facilities have physician employment arrangements that stipulate that they must provide charity care, but most don't have the full complement of physicians across the spectrum of specialties to provide all the necessary professional needs. Several factors, including those greatly articulated by Dr. Page, but also including professional fees and liability considerations, limit the number of qualified physicians that are willing and able to provide charity care. In some states, it's extremely difficult or nearly impossible for physicians to find charity care for their patients. And except for free clinics, there's not a whole lot of advertising very publicly for facilities that offer free services. And some free clinics that do advertise report a 6-month waiting period to see new patients. So it's a challenge to find physicians to do charity care and to find the facilities that provide it. Also, charity care financially restricts physicians. Physicians receive no tax benefits for providing charity care. They cannot write off the cost of charity care from their personal or business taxes. The current tax code only allows for deductions for certain out-of-pocket expenses in providing charity care, like travel expenses, but it does not allow for such deductions for the value of a physician's time or for the professional service itself. So AMAC is aware of all this, and we wanted to come up with a way, how could we assist physicians in providing more charity care and expanding access to it? So we came up with legislation. This bill is called, it's House Resolution 856. It is the Physician Pro Bono Care Act of 2019. We are currently seeking co-sponsors for this in Washington. We have 20 or so bipartisan co-sponsors for this bill. And what it does, HR 856 allows physicians to provide pro bono care to Medicaid and CHIP eligible patients in their offices. So physicians would take a simple tax deduction, we estimate at 32% because that's the highest allowable under the tax law, in place of taking Medicaid reimbursement. So they will have the option to take a tax deduction or accept assignment from Medicaid and CHIP. The deduction would be based upon the value of the services they provide, based on either the Medicare reimbursement rate or their usual and customary posted fees in the state or county in which they're located. Now, right now, I just want to run some numbers by you to show the significance of the savings to Medicaid with HR 856. There are 50.8 million Medicaid and CHIP eligible patients. They visited a primary care physician in 2015. Medicaid paid on average $106 for these 45-minute visits. Under House Resolution 856 of the Physician Pro Bono Care Act, if these same patients sought care at that same average of $160 for an office visit, and the physician was allowed to take a 32% tax deduction, the cost of this visit to Medicaid would be $50. And the savings generated by, for the Medicaid and CHIP program by the Physician Pro Bono Care Act would be about $2.8 billion, or less than 50% of what Medicaid pays out. And everybody on this call, or everybody that are tuning in for this panel, knows that patients, low-income patients, also seek primary care, usually in emergency rooms. 20 million Medicaid and CHIP eligible patients sought care at least one time in an emergency room in 2015. Medicaid paid $1,000, over $1,000 per ER visit. That cost the program over $20 billion. If only 7 million of these nearly 20 million patients went one time to a primary care physician at an average of $160, and that physician was able to take that 32% tax deduction under the Physician Pro Bono Care Act, the cost to the government would be $358 million in tax deductions and not reimbursements. That's 1/20th the cost to the Medicaid, the payout that Medicaid was paying for the ER visit, and would save the program $6.6 billion. And that's for one visit only. So the bill will increase access to medical care for the poor by providing an incentive for physicians to see more of this population. It also guarantees an alternative to institutional care and the corresponding hospital emergency room costs that Medicaid and the CHIP programs pay out. It'll reduce the federal and state demand for reimbursements by allowing patients from these programs to visit primary care physicians for non-emergent situations. We're going to extend this bill to include dentists, podiatrists, and chiropractors. So what we think this bill would do would increase the quality of care, because that Medicaid patient will be able to establish a relationship with a primary care physician who now has the option, this is an option, to take a tax deduction instead of going through the cumbersome process to get the chintzy reimbursement from Medicaid. So we think that relationships will be established. We also think that health outcomes will rise because of those relationships. So what the bill does is give physicians the opportunity to do charity care in their own offices and be able to take a tax deduction for their time and their professional services. As I said before, we are currently seeking co-sponsors on Capitol Hill. We have about 20 right now on both sides of the aisle. And I just want to thank the panel for the opportunity to talk about charity care, to join this esteemed group, and to talk about AMAC and our House Resolution 856, the Physician Pro Bono Care Act. And that's what I have.
All right. Thank you, Mr. Mangione. There is a question for you. Brian Sachs, love this idea. Curious on any hidden legal pitfalls for physicians, and why only Medicaid and CHIP?
Well, we started with Medicaid and CHIP because they are the most vulnerable, okay? And AMAC is a member of the Free to Care Coalition. We've had a number of discussions with physicians, informal, that tell us, you know, I would see more Medicaid patients if I didn't have to go through the process. They're not opposed to seeing these patients. It's the process of getting reimbursed, however chintzy that it is, okay, that turns physicians off, and they spend a lot of time chasing down these payers to get paid. So we thought we'd start with the most vulnerable, low-income individuals and families, as look, you know, to reform healthcare is a colossal, multifaceted project. We thought we'd start with low-income people first. That's why we took a look at this and then expanded based on the reaction and if we're successful in getting this bill passed. As far as there's a Good Samaritan provision that's built in there that should shield people from legal liabilities. That's built into the bill.
That's great. Excellent. I think that's a excellent solution. So easy to implement. I don't even understand
Nikki,
this bill.
You're right. And Dr. Johnson, if I could just say, this is just a simple change to the IRS tax code. And to kind of piggyback on what Dr. Page was talking about regarding rural healthcare, this could be a stopgap in an area where a rural hospital is closed. How many primary care offices does that Medicaid patient pass up to seek primary care in the emergency room? So we know that rural areas are getting hard hit with these closures. We think that this bill could be a stopgap in a primary care perspective in an area that lost a rural hospital.
Absolutely agree with that. And with all the stats we just heard about for rural communities, high reliance on Medicaid and Medicare.
Exactly.
This would definitely make a large impact, and it's just so simple to do. And I bet if we were to poll the physicians participating in this, or we could find out that most physicians would actually do more pro bono care if they could, and if they could actually get reimbursed. People don't realize that physicians still do need to keep their practices open, and you can't keep your practice open if you're giving away care and not getting anything for it at all. and also not facing penalties and bureaucratic, mountains of paperwork to have to be able to do it. So, I'm sure the incentive is there.
Exactly right, Dr. Johnson. Physicians, it's not like they're not used to providing charity care. They want to do charity care. We'd like to give them the opportunity to have them do it in their office. I don't think that's asking much. And the conversations we have with politicians on Capitol Hill, we get a lot of heads nodding. We really do. They feel for patients. Okay, getting them to commit is another story as far as co-sponsorship goes. But we're doing everything we can, and we're doing a full court press on Capitol Hill to get this bill more co-sponsors, get it to the Florida House. We're working the Senate as well. We just met with Senator Mike Braun of Indiana yesterday, who really likes this bill, and healthcare reform is high on his priority list. So we're getting a lot of traction for this, and we're happy to. We're just happy to do this work on behalf of the poor and on behalf of physicians who want to do this work.
What do you think that physicians who are out there practicing in the communities can do to actually help push this act forward?
I think they can join excuse me, Dr. Johnson. I think they could join the coalition. All right. I think they can pick up the phone and they can call their congressman and say, would you please support HR 856? Every legislative assistant and legislative director in Capitol Hill has access to all the bills that have been filed. This bill has been sponsored. It was it's sponsored. It's been introduced, so it's on the record, and they could have their congressman familiarize themselves, and they can with the bill, and the physicians out there can ask their congressman to acquaint themselves with HR 856 and become a co-sponsor. As I mentioned before, we've got members of Congress on both sides of the aisle that are sponsoring this.
Where does AARP stand on this bill?
We have reached out to AARP, and we don't get a whole lot of response from them, unfortunately. We'd like to work with them on specific issues. They've got a different agenda with regard to healthcare reform. We have a tendency to look through the problems that are facing America, and in specific healthcare reform, through the lens of free markets. And we find ourselves usually, as much as we'd like to work with another large senior organization, we find ourselves, and I would say AARP finds themselves on opposite ends on how to solve the problems like healthcare, the solvency of Social Security, and et cetera. It's not like we don't want to work with them, Dr. Johnson. We just don't have much success in doing so.
Interesting. And what's been the biggest pushback, either from Washington or from outside influencers?
There really hasn't been pushback. If anything, it's the problem we're having is getting a politician to make a commitment to this thing, getting them to commit to anything. Everybody's head's not in agreement. Okay, one office said, well, they didn't think the 32 tax deduction was enough to incentivize physicians. And I said, hey, you guys could mark this up. You could make it a 50% deduction. You could do whatever you want. And that was a good objection. But nobody has said it won't work. Everybody recognizes the need for charity care. They just need to have the picture painted that doctors have to, must be empowered to do this in their offices. And they were unaware that doctors are not able to write off or take a deduction for their professional services. They're aware that they can take their travel expenses to drive to the free clinic, but they do get the idea that this will increase access. But nobody has said it was a bad bill. If anything, it's getting a politician to commit to co-sponsoring this. So we haven't heard anybody say this will never work. Most people say, in fact, everyone I've talked to said, boy, this is a great opportunity. Let me think about it. And getting them to move from thinking to co-sponsoring is where we're at right now.
Okay. There's another question for you. I believe this is directed to you from Ernest Sussman. Be interesting if other specialties establish urgent conditions that could be handled in their office also. What are your thoughts on this?
I think the bill can be expanded. We think this is just the beginning. Okay, we think this is just the beginning of a free market solution that will empower physicians across the board, above and beyond primary care.
Awesome. I agree with you. Healthcare, this medical care mess that we have right now in the United States, it is huge. So we do have to tackle piece by piece. There's no way one sweeping piece of legislation is going to fix all the problems we have. We've seen this happen with the Affordable Care Act. So there's too many special interests that try to get a piece in there. So I think tackling it bit by bit, putting all the bits of the puzzle together is going to be the best way to tackle this. So this is a great start. Let me just I think that's it for the questions that are directed to you, Andy. Thank you very much. This was awesome. Well done. Let's just double check and make sure there are no other questions. Mary, Dr. Mass has a thought, more a thought than a question. Much of America views physicians as wildly wealthy, not the reality, especially for many debt-saddled young doctors. Pointing out the doctor debt burden and how this bill could help, especially these younger physicians, might be helpful too.
Absolutely.
Yep. Okay. And I think there was also one more question for Carl. Are you still here, Carl?
He's muted.
Yes, ma'am. I'm here.
Okay. There's one more
There have
question.
been no deer. I had a feral cat run by me.
Darn.
I saw a feral cat, but I didn't do anything.
Okay. Actually, there's two questions for you. One's from Dr. Bob Campbell. The DC powers are out there trying to basically crush DPC. Will BUCAs come after you if you grow in scale? And is there any evidence that this is happening right now?
Well, I can tell you this much, and I'm gonna be careful. Mr. Blatt told me to, be careful, but I'm gonna tell it like it is. All right, I'm gonna tell you something. We're working with a school district, and the CEO of one of the BUCAs, $45 million CEO a year, not the president of the state, the head guy, came down to meet with them with the things we're doing. This is a cartel, folks. We have another city we're working with that the person we're partnering with was approached by one of the BUCAs asking, "Hey, what are you doing over here?" I'm trying to help the city. Well, we don't like that. I mean, it is a cartel. It's an organized crime mafia. You pick your term. Yeah, they will. Look, I have a Schuessler stick, Dr. Johnson. It's a metal rod with a mirror attached to it. So before I crank my car up, I use it every day. So yeah, it's going to cause problems, folks. But guys, you got to be tough and you got to do something. I watched my dad. I mean, he had a great career, but I watched the stuff he went through, and we just have to stand up and fight. But I know the DPC challenges. Dr. Gross, Dr. II, Dr. Gold. Dr. Umber and everybody's up there fighting, and I apologize I left anybody off, but you can beat them and you can win, and we just have to do it one employer at a time. And I'd love to scale it. I'm a member of the Health Rosetta, and I've got about 130 advisors that think like I do, and we're all trying to work together to scale this, Nicole. And but yeah, absolutely. But they're not going to go quietly, guys. One last thing, I apologize for rambling on. Who knows how much the healthcare industry spends in lobbying? Anybody? I know nobody can talk because they're muted. It's over $600 million. $600 million. Now I thought it'd be billions. $600 million. Do you know how much defense, aerospace, and oil and gas spent? They're kind of big industry, somewhat. How much do you think they spent, Dr. Johnson? $315 million. The healthcare industry spent twice as much as those three huge industries combined. So, and a lot of that's coming from the pharmacy, from all of that. So, and obviously the insurance company. So, I'd love to talk to you, doctor. Absolutely. Let's go. I'm suited up and ready to roll. I got my rifle. Let's go.
Okay. And I think there's one last question just to wrap up for you. Do you know how many mid-level practitioners were used in your model that you presented to us versus actual physicians?
Mid-level practice, a great question. We've got the two doctors, Dr. Crouch and Dr. Gross, the DPC practice. And just really any doctor that is employed at the hospital, I can't get more specific. I mean, they hired their first full-time surgeon, hope to bring obstetrics back. But we use doctors all over the country, wherever the people require care. So, we did have a couple. I will tell one fast story. We had 3 deliveries at a very, very expensive cartelish hospital, as I like to call it. And by the way, the hospital leadership, when I came and met them, they go, I said, the cartel, and they go, do what? And then as we were talking to a lot of hospitals, they, started to kind of see that. But we negotiated, this particular hospital charges $37,000 for a vaginal birth, Dr. Johnson. $37,000. I told my dad that, and he about fell out of his chair. We were able to negotiate a cash price for $7,500. That's what you can do. And the other thing with these hospitals, folks, one last thing. You want to help these hospitals, you want these rural hospitals, design health plans that pay the hospital 30 days in advance, like we did that delivery, or that pay on the spot, or pay within 30 days. Most of the FUCAs are 90-day, accounts receivable. So there are ways to do this, and these hospitals will talk. You do not have to be IBM to negotiate a contract with a hospital. You do not.
All right. Thanks to everybody for attending the discussion. I think we're off to a great start this morning with some actual solutions in this fight. One other request for Andy Mangione. Could you provide a 1-page summary for Free to Care that we can share with members in our individual organizations, Bono Care Act?
I would be happy to.
Awesome. All right. Thanks, everybody. I'm going to turn it back over to Brennan. And
Thank y'all. Have a great day. Go Dogs.